in many different areas of radiation protection. So today he will speak about new information on high patient radiation doses undergoing imaging exams. And we'll see if we have it ready here for playback.
Thank you, Dana. Thank you, organizers, for the invitation to speak in this very useful session in this wonderful conference. I'll be presenting new information on high radiation doses to the patients. These new findings are somewhat eye-opening, and they were not evident from previous studies during 2009 to 2018. The relatively high doses typically come from some imaging modalities like CT, hybrid imaging, fluoroscopy guided intervention, some nuclear medicine exams, and imaging and radiotherapy. Let's start with CT, which is the major source. The International Action Plan of IAEA was the one which started actions on radiation protection of patients way back in 2001, which was followed by various actions by various societies and organizations as listed in this, and it led to the various national and regional campaigns, including AFROSAFE and ARABSAFE. By 2018, most organizations were patting their back for having done an excellent job of patient dose management. And it was only in 2019 and 20 when it was realized that we were not really looking at something during that time. And we chose the value of 100 millisievert because more than 60% of the exposed survivors in A-bomb had received the dose of radiation less than 100 millisievert. And 100 millisievert dose will typically lead to more than 100 millisievert organ doses. So we published 3 papers almost simultaneously. They were submitted in mid-2019 and they were brought online in December 2019, and of course the published version in April 2020. All these 3 publications were published in European Radiology, and they dealt with various aspects of patients who were getting more than 100 millisievert from recurrent CT exams. The summary of findings from these 3 papers was that almost 1 million of patients, that is 0.9 million patients, are likely getting added every year on a global scale with cumulative effective dose of more than 100 millisievert, and that's only from the recurrent CT exams. We ourselves had some doubt on the extrapolation figures which we arrived at, because no one had in the past mentioned that, and the values appeared very, very high, that almost 0.9 or nearly 1 million patients of 100 millisievert getting added every year. So this was also unbelievable and shocking to most of the professionals in the field. Then we verified this with the help of a biostatistician from Germany, and we used our dose coefficients and figures to estimate further the doses to the patients in 35 OECD countries, and we found that on the highest side was US, followed by Japan, Iceland, Luxembourg, Turkey, Korea, and on the lowest side were Finland, Slovenia, Italy, and all that. So it confirmed that our estimations were correct. So in such situation, whenever patients' high doses are pointed out, there are three typical questions which come up. First, patient may be over 50 years of age where radiation effects may not be that critical. CT scans may not have been optimized, or they have been overused and they may not have been justified. So we settled all these three questions in the large study in which we had millions of patients. Although we found that largest fraction was in the age group of 61 and above, but there were nearly 20% of the patients who were below 50 years of age. So practically 1 in every 5 patients was below 50 years of age, and the values ranged from 13 to 28%. Also, we looked at the justification. We at MGH in my hospital have the clinical decision support CDS available since 2004, and MGH is the global leader in this field of justification in medical imaging. So we found that most exams were justified, and when it comes to optimization in our hospital, we compare our median values with the national benchmark, and they were all the time below the national benchmark by a significant margins. So the outcome was that despite using the best form of justification available today in the world and the best form of optimization, and the patients with high cumulative doses were highest in our setting as compared to the others, maybe because of the complicated cases we receive as well as the many clinical trials that we have. But the point is that when it comes to the patient protection, there is need to do something different. So what we know today is that patients with 100 millisievert plus are fairly large in number, and this is probably possible even when best form of justification and best form of optimization currently available is being utilized. Can anyone think of a time in the last century or more when there was a similar situation? Of course not. Many times we hear people saying that if I am prescribed a CT scan by a doctor, I will not think a bit about the radiation risk. This may be true, but they or we are not among those in whom cumulative dose is of concern. So not that 100 millisievert forms the threshold for radiation effects, but at that level of dose, many organs have radiation dose more than 100 milligray, where the radiation effects are well known to occur, and there is an almost consensus on that. In this paper, we had studied that in the cohort of patients with 100 millisievert plus, there were many organs which were in the range of 100 to 200 millisievert, 100 to 200 milligray of organ dose, 9 organs, and some organs like stomach and liver had more than 200 milligray. In fact, following our paper, there have been large number of publications in the last 3 years, one by the ESR and then many from the many other European countries, and there are quite a good number of them. One can just quickly go through them. So remember, this is what we felt few slides before, that organizations were patting their back for having done a good job in CT, but obviously there is no chance to sit back and relax, and there is a need for further action. A question which was raised was how much is likely to be the minimum time for a patient to get 100 millisievert, and we were really surprised that in all the 4 institutions through which we had data collection, the minimum was 1 day. So with that preliminary finding, we thought of settling this issue in a large study covering millions of patients, in which our objective was to find the number of patients who are getting more than 50 millisievert through a single exam, single CT exam, and more than 100 millisievert in a single day. So we found through the many millions of patients that 1 out of every 125 patients obtained more than 50 millisievert through a single CT exam, and 3 out of every 10,000 patients received more than 100 millisievert through a single CT, through the CT exam in a single day. 9.4% of the patients underwent more than one CT exam in a single day. Going over to the PET CT, we also did work on that in our hospital, and we find that 1 of the 5 patients had more than 2 PET CT exams in a calendar year. Nearly 12% of them were below 40 years of age, 27% were in 41 to 60 years, and remaining 61% were over 60 years old. So our ultimate finding was 1 of the 8 patients received cumulative effective dose of 100 millisievert, and there is another study under publication from Turkey, a large study of 11 years, in which we found that there were 1 out of 4 patients in more than 100 millisievert. And we also found which are the top 3 malignancies associated with imaging, with multiple PET CT imaging, and not all of them are the incurable ones. So there is a large number of patients. So interventional procedures, we published this data from our hospital of patients who obtained more than 100 millisievert through fluoroscopy guided intervention, and we found that 4% of our patients received cumulative effective dose of 100 millisievert or more. So that was the situation. So in a way, if we look at what I have presented, 1 out of every, almost on an average 100 patients undergoing CT scan, that is 1%, had cumulative effective dose of 100 millisievert in few years. 1 out of 8 or even 1 out of 4 of those who are undergoing PET CT, 1 out of 25 patients or 4% of those undergoing fluoroscopy guided intervention. So the question arises, is this radiation protection? Is there not enough for us to do? At the moment, we still do not know how much is the total dose patients are getting from all these exams combined. So essentially the message is that we have been focused on exam dose quite a bit. We need to focus on the patient dose. This was a special issue of the British Journal of Radiology containing many papers on recurrent imaging, and an editorial I draw your attention. To recap, we have provided new findings of 100 millisievert and 100 millisievert in a single day, and CT, PET CT, fluoroscopy guided intervention. So this is unique time in the history. Thank you very much for your attention.
I would like to say thank you very much to our last speaker, that he's not here, but I'm sure that Ola will pass our thank you to him when you see him over the weekend. And now thank you very much for everyone who is still with us in this last session. And I guess that it wasn't any questions. So in the end, I would like to show our appreciation and saying thank you to Professor Dina, who organized this fantastic session, just to show how important it is that we'll talk and remember about the radiation protection. And thank you very much to the fantastic chairs who are here with me. So thank you for being here, and I would like to invite everyone to the opening ceremony in Hall A. Thank you.